neck of femur is devoid of, that means there is no or there is absence of, devoid of cambium periosteal layer. You know, we have already talked about that periosteum is basically made up of two layers, the inner and the outer layer. The inner layer is a cambium layer which has got osteoprogenitor potential, and that inner cambium layer of the periosteum is responsible for the formation of the bone, or it assists in the formation of the bone. If the cambium layer of the periosteum is not present, if the region which is having the absence of the cambium layer of the periosteum, that region gets fractured, then it will be a disadvantage on that region, because the aid which could be provided by this cambium layer of periosteum is absent. All right, so these are the three reasons which are responsible for causing non-union. Only thing which you are not able to understand at this point, that how this intracapsular presence of the enzyme is responsible for creating non-union. That, as I told you, you will come to know after some duration of time. So before we talk about those causes, it is important to have a discussion on the stages of fracture healing. So let's interrupt the topic, or let's discontinue the topic fracture neck of femur. We are talking in between the stages of fracture healing. You know, fracture healing is basically achieved by two types of fracture healings. One is healing by a primary intention and by the secondary intention. So primary intention is that, imagine if these are the two fractured ends of the bone, they are attrited to each other, and they are fixed by the placement of a compression device. All right, so with the cut and cone, there will be a union achieved at the site of the fracture. That is by primary intention. Secondary intention is the union which is achieved through the process of callus formation. You know, a natural healing of the bone or natural union at the site of the fracture. That is secondary intention. So here we are going to talk about the stages of the fracture healing by secondary intention. What are those stages? The first one is the stage of hematoma formation. Now what happens in this stage of hematoma formation? Just try to understand. Imagine this is the fracture site, and once there is a fracture, there will be a collection of blood. So there will be a collection of the blood around after the fracture. This accumulated blood or the collected blood will be converted into a clot, which will act as a bed for the collection of all the ingredients which are required for the union at the site of the fracture. So this is a stage of hematoma formation. That is first stage. Then the second stage is the stage of granulation. As I told you, granulation is the stage of inflammation where all the inflammatory mediators which are responsible for initiation of the fracture union at the site would be activated. So there will be a formation of a granulation tissue around the fracture site. Now, over a period of time, what will happen? That this granulation is a naive tissue which could be converted into any based upon the stimulus it is receiving, and here around the fracture site it is continuously receiving the stimulus of bone formation. So this granulation will ultimately get more and more calcified, more and more consolidated, leading to the formation of a callus. Now what are the two important prerequisites, or what are the two important specificities associated with this callus formation? One is that it is the earliest X-ray finding of fracture healing. Can you see the hematoma on the X-ray? Obviously not. You cannot see the granulation, inflammation and all the stages of inflammation. You cannot. But once it is getting converted into a callus, it will be appearing on the X-ray. But it will take some time for its appearance. And it appears at least 3 weeks after the fracture. Means it will take this much of time for its appearance on the X-rays after the fracture, that is callus. And callus is further classified into soft callus and hard callus, because it will be consolidated callus over a period of time. There will be a consolidation of the soft callus into a hard one. When the person starts using that bone, it will be subjected to a normal change of a bone remodeling and modeling. So the bone will be remodeled according to the shape, according to the forces which are applied to the bone. So there will be a stage of remodeling and modeling over a period of time, and the bone over a period of time will attain the strength as well as the structure of a normal bone. So these are the stages of fracture healing. All right, now what out of these stages, the first one is the stage of hematoma formation. The first stage obviously is the stage of clot formation. which is responsible for creating a bed over which all the ingredients which are required for the union at the fracture site would get accumulated. Now imagine if there is a presence of enzyme which is present, and this enzyme is responsible for breaking the clot. So is this enzyme not interfering along the stages of fracture healing right at the first stage? It is interfering right at the first stage of the fracture healing, and that is the reason why fractured neck of femur are more predisposed to go into non-union because of the presence of this intracapsular enzyme. Next, you will ask that why the nature has provided this enzyme which is preventing this union at the fracture site from happening. The reason is, joint is a mobile structure, and if there is no such enzyme which is provided in the joint, then every time there is a small collection of the blood, it will be converted into a hematoma, and that hematoma over a period of time will lead to restriction or stiffness of the joint. So it is a basic requirement by the nature that there shouldn't be anything inside the joint intracapsularly, so that which restrict the movement of the joint. That is the reason any hematoma, any clot is going to be distributed is going to be disrupted immediately by the action of this enzyme, that is hyaluronidase. So these are the reasons why non-union is a prevalent complication in fractured neck of femur. Now it will become much easier for us to understand the three classification systems associated with the fractured neck of femur. The first classification is the anatomical classification. Anatomical classification. Now, under the heading of anatomical classification, again, by a rough diagrammatic representation, we'll be talking about this. Anatomically, the fractured neck of femur can be classified into three different types. So, it could be a fracture which is just below the level of the head, a fracture which is passing through the center of the neck, and a fracture which is passing through the base of the neck. So, accordingly, they are named as subcapital, then transcervical. As the name indicates, cervical means neck, so transcervical means through the cervical, subcapital means just below the level of capit, that is head, and basicervical. So these are the three types of the fractured neck of femur. Now, what is the significance? What is the outcome? What is the prognosis related to these fractures? The significance is that proximal the fracture, poorer the prognosis. That means out of the three fracture lines, that means subcapital, basicervical, transcervical, which one will be having the highest chances of non-union? It will be subcapital. Which one would be having the highest possibilities of avascular necrosis head of the femur? It will be subcapital. It does not mean that basicervical or transcervical cannot have these kind of complications, but the possibility of these complications are higher when it is proximally, the fracture is affecting the proximal most part of the neck. Alright, that is the importance of anatomical classification. Then another classification which again is going to be talked about based on its anatomical representation is the Powell classification. The second classification is the Powell's classification. Under the heading of this classification system, again by a rough diagrammatic representation, if this is the head, this is neck, this is greater trochanter and lesser trochanter. Now imagine if we draw a horizontal line along the neck. All right, this is the imaginary horizontal line, and the two fracture lines are going to be compared with the angle created along this horizontal line. So we are comparing two fracture lines. This is fracture line A and this is fracture line B. So imagine this is fracture line A and this is fracture line B. So out of these two, which one is subtending a greater angle with the horizontal? So obviously A is creating a greater angle with the horizontal compared to B. So what is the significance of this classification? That greater the angle in between the fracture line and the horizontal, poorer the prognosis. Alright. So if I ask you a question that out of these three fracture lines, one is subtending an angle of 30 degree, 50 degree, 70 degree, which one will be having the worst prognostic outcome? It is the fracture line which is creating an angle of 70 degree with the horizontal. Alright. So this is how the Powell classification is significant. Now some of you might be wondering that how this angle differences are responsible for changing the prognosis along the fracture neck of femur. The reason is, Imagine if there is more angle, then there will be more distraction. When there will be more distraction, there will be more separation in between the fracture fragment. The more the separation, the lesser the chances of union, because the lesser is the contact in between the two. All right. Lesser the angle, lesser the distraction, more the contact, more the chances of union. Hopefully you have understood how the Powell's classification works. And then finally comes the Garden classification. All right. Now Garden classification can be described into two forms. One is theoretical, other one is practical. So let's have a discussion first of all on the theoretical classification. The name of the classification is Garden. Now under the heading of Garden classification, what exactly or how it is theoretically written, the type 1 Garden classification is incomplete fracture line. You know, if this is the neck of femur, for example, all right, the fracture line is not involving the opposite cortex. There is only a one cortex which is affected. That is incomplete fracture line, and that is the reason why it is also known as, so this type of a fracture is also known by the name of valgus impaction fracture. You know, if there is a lateral compression which is responsible for impacting the head of the femur and neck of femur in the valgus position, thereby causing a break in the lateral cortex of the neck of femur, only is known as a valgus impaction fracture. That is type 1 fracture. Now type 2 is going to be a complete fracture, means the fracture line is complete, but there is no displacement at all. Now how is this thing going to be understood? Imagine if this is the neck of femur we are talking about, the fracture line is complete, involving the entire cortical region, but there is no displacement at all. That is type 2. Out of these three types, the type 3 is going to be a complete fracture but with the partial displacement, means to some extent displacement has happened. Imagine this is the fracture line, still they are in contact to each other but not entirely in contact, means to some extent it has been displaced. And finally the type 4 is going to be a complete fracture with complete displacement, means there is going to be a completely displaced fracture. All right. So this is how theoretically a Garden classification could be understood. All right. Type 4 are the types we have discussed. Type 1 was incomplete. Type 2 is complete but undisplaced. Type 3 is complete with partial displacement, and type 4 is completely displaced fracture. That is type 4. So obviously out of these 4 different types, the type 4 is going to have the worst prognostic outcome. All right. While type 1 would be having the best prognostic outcome according to Garden system of classification. Now there is another way of studying this Garden system of classification practically. Means how? Practically, just by looking at the x-rays, you would be able to delineate or distinguish how the Garden classification should have been analyzed. Now before we talk about that analysis or in the fractures, let's have a discussion on the trabeculae in the normal head of femur. All right, normal hip joint trabeculae. You know, this is the weight bearing axis on the head of the femur and the acetabulum. This is the weight bearing axis. So obviously the weight bearing site of the head of the femur, neck of femur and the acetabulum would be more calcified. It should have more strength. So that calcification or that strength is arranged or aligned along the weight bearing axis in the form of a calcified trabeculae. So normally what we tend to see over here are the trabeculaes. How these trabeculaes are going to be identified? Along the weight bearing axis, this is the more calcified vision of the neck of femur, head of femur and the acetabulum along the weight bearing axis. All right. So this is the acetabular trabeculae, this is head of femur trabeculae, and this is the trabeculae of the neck trabeculae. And all of them, all three of them are aligned, smooth alignment along the weight bearing axis. Now how this alignment is going to be changed in all the different types of Garden system of fracture classification. Now in type 1, obviously there will be a fracture on the lateral aspect. So to some extent, what will happen, if this is the acetabulum, this is the head of the femur. So to some extent, because of the valgus impaction, what will happen, there will be an attrition. All right. To some extent, there will be attrition, and there might be some amount of changes observed in the trabecular factions. All right. So the